Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. Thanks for joining me for our final episode dedicated to the Choosing Wisely campaign, a movement designed to promote high-value care and reduce unnecessary interventions. As always, I'm your host, Dr. Becky Carson, pediatric nurse practitioner and clinical faculty at the Duke University School of Nursing. If you've been following this series, you know that I love connecting clinical decisions back to the pathophysiology that drives them, which is why the Choosing Wisely campaign is right up my alley. Today, we'll summarize some final thoughts for why more is not always better, and how this principle can transform your pediatric practice in a final case study that is all too commonly missed in practice. If you'll remember, the Choosing Wisely campaign, launched by the ABIM Foundation, is all about high-value care that achieves optimal outcomes while minimizing unnecessary interventions. At its core, it's surrounded by ethical principles that are central to nursing practice. Beneficence, choosing interventions with proven benefit. Nonmaleficence, avoiding harm. Autonomy, engaging families in shared decision-making. And justice, ensuring equitable access to limited resources. When we eliminate unnecessary tests and treatments, we're not stealing from our own pocket or writing ourselves out of a job. We're creating access for others, reducing waste, and improving care quality. Well, so why do we overdo it? Here's the reality. At least 20% of healthcare interventions add no value, and most clinicians admit to ordering unnecessary tests on a weekly basis. Why do we do this? Well, there's a few reasons why. One could be that they have discomfort with uncertainty and the desire to appease anxiety, whether theirs or the caregiver's. That discomfort is an uncomfortable emotion that we seek to mitigate, even when it's the wrong thing to do. It's the "I just want to make sure" mentality, as it meets some doomsday differential with a total lack of clinical application. Maybe there are perceived patient and family expectations. When the reality that healthcare centers on a customer service mentality conflicts with evidence-based practice, we see a total abandonment of evidence-based practice in order to get a 5-star Yelp review. Maybe it's that providers have malpractice fears in a litigious society, when, in fact, what families crave is a standard of care and providers who are capable of recognizing salient clues. Maybe there are financial incentives. When you are paid based on RVUs, the more you order, the higher your billable reimbursement can be. So there's a direct incentive to order more so that you can be paid more. And that's when the money starts doing the ordering. Then there's workload. Our time is crunched, so the workload and its accompanying stress can be palpable as the waiting room swells. Production pressure refers to the demand on healthcare professionals to increase the quantity of work at the expense of quality. It feels easier to go with the flow of parental expectations and anxiety. 15 minutes for a well visit and mounds of priorities that you need to discuss means that you're likely going to refer a common primary care issue. Let's say something like infant reflux that just hasn't gone away despite great growth, no pain, and no red flags. Just laundry that's frustrating the parents. So you refer that to Peds GI to let them handle it because the specialist will definitely have more time to talk about it because, frankly, education takes a long time, especially when it feels like an argument. Which brings me to this. We have too little time for discussion. How many times have you heard me say, spend 5 more minutes sharing your brilliance with families? Cite the articles that will support your plan and help them to understand the science and evidence in support of your management. I know it's easy for the educator who spends all day reading articles that come across my desk to say, but That's a key reason to stay plugged into lifelong education, and it's going to help you make evidence-based decisions. And lastly, we hold tight to habits from training. Well, this is how my preceptor did it, or this is what we always do at my organization. This blind faith results in habits that represent deviance. McMullen et al. Told the background of the term and how normalization of deviance has a historic origin. They tell us that arising out of the Challenger space explosion in 1986, sociologist Diane Vaughan defined normalization of deviance as the gradual process through which unacceptable practice or standards become acceptable. As the deviant behavior is repeated without catastrophic results, it becomes a social norm for the organization. This normalization of deviance has been found to occur in healthcare environments when providers, due to a variety of factors, they cut corners and they fail to implement evidence-based practice standards. I view this head-in-the-sand approach to implicitly following habit or custom to be a major gap to implementing evidence-based practice with thoughtful decision-making that is rooted in science. And honestly, it's a major source of error that can actually be risky for children, because not choosing the right management comes with delayed diagnosis, side effects of unnecessary medication, and adverse effects of inappropriately choosing diagnostic studies or management strategies. My students know how to handle this, and if you need a refresher, just listen to episode 23, Trouble in Clinical Paradise, to understand what it looks like to have a professional disagreement and seek clarity when the clinical picture does not match the management plan. Do any of these sound familiar? All of these pressures, whether they exist independently or in combination, often push us towards doing more, even when the evidence says less is better. Let's get started with our final case that will challenge the reflexes to jump to the first diagnosis that pops into your mind and the tendencies that tell you to do more. All right, imagine yourself in an ambulatory setting for a moment. It could be a private practice, an emergency department, or an urgent care. It's a warm and sunny day in early September. All the children with swimmer's ears have gone back to school, and you're starting to see some more of the seasonal bread and butter pediatrics trickle in. On the board in the waiting room is an early school-age boy with dysuria. Now, because I've been around the block once or twice, or, 15 or 16, I place my lottery ticket on a common pediatric presentation, and I watch the well-appearing child walk into their room after a quick set of vitals. The child is a first grader and reports pain, frequency, and urinary retention since yesterday. To top it all off, he had an episode of enuresis at school. The mother rushes him into the clinic because she's had UTIs before, and this is exactly how they start. She tells you that last night he was writhing with stomach pain, crying frantically. She gave a dose of acetaminophen because she didn't want him to have ibuprofen on an empty stomach. No fever, no nausea, no vomiting, no back pain. His belly does not hurt at this moment, and a quick review of his chart reveals that he's previously healthy and was circumcised at birth. He's well appearing on exam, and I'll hit some of the high points below the belt. His abdomen was soft, round, and non-tender, normal bowel sounds, no organomegaly, no CVA tenderness. His GU exam showed normal Tanner 1 male development with a circumcised penis and bilaterally descended testicles. I'll pause here for a moment and ask, do you have a strong inclination without adding any more history items? Was a urinary tract infection your primary concern after the mother directed your attention to it? Did you factor in the child's age and sex? Urinary tract infections are more common in males under 1 year of age, most likely because of congenital anomalies. But after that initial infancy, they're more common in females. Only 1.7% of males will have a UTI before 7 years of age. And that's because males have a long urethra that is more distant from sources of stool. Sure, there are some risk factors for UTI in children, but none are present here. No congenital anomalies, history of urinary tract infection, diabetes mellitus, or immunodeficiency. It feels like we need to ask some more questions and extend our physical exam. And if you were thinking about every first grader you know, you're right. We need to talk about poop. A little more digging into the history uncovers that this child is having hard, difficult to pass Bristol 1 and 2 stools. The external exam reveals a normal anal wink without any anatomic differences, such as a sacral dimple or tuft of hair. The mother is certain that it's a UTI because she thinks he doesn't wipe well. His underpants always have stool left behind. Aha, bingo. Okay, sidebar. As much as kids love talking about poop, they also love talking about candy. And that's the easiest way to figure out what their stool looks like. Trigger warning, we're about to get kind of gross. Bristol 1 hard pellets are analogous to M&Ms or Hershey Kisses that are typically difficult to get out. Bristol 2 is more like a payday candy bar. They're individual peanuts, but they adhere together, and that can also be painful. Bristol 3 is more like a Snickers. It's sausage-shaped, but still has lumps and cracks. Bristol 4 is like a Mounds with smooth, soft edges, tapered at either end, and is typically painless to stool. Types 5, 6, and 7 are not indicative of constipation unless you're talking about Hershey squirts. Those are the streaks of stool left over in the underpants that parents often attribute to poor hygiene when they really indicate encopresis that occurs as a result of liquid stool leaking around a rectal impaction that leads to fecal soiling. And now that I've ruined all of your favorite candy bars, let's get back to the case. So we've got hard, painful, small caliber stools, and you intuitively recognize the link between these symptoms and the start of school. So changes in weather, diet, and routine are key factors that can affect bowel habits in children. I often notice an influx of constipation complaints when the weather gets hot for the first time in the spring or summer, and each time children return to school after a break. Why is that? Because the bathroom is kind of a scary place at school. It's not private, it smells bad, they're often not clean, and kids can be mean when you're the one that made it smelly. Coupled with the fact that teachers want their pupils to learn at school, so they don't let them have water at their desks because that would lead to bathroom breaks. So that means that kids are a little dehydrated and holding their stool all day. So they hold it, so the stool has more water to be absorbed, and it gets harder. So hard stool is more difficult to get out, so it stays around longer and gets harder, and then it gets more painful, and then they hold it because that hurts, and eventually this vicious cycle leads to functional constipation. And now that we're talking about this child having encopresis and a new onset of enuresis, we have a pretty clear case of bowel bladder dysfunction. Kids with bowel bladder dysfunction have a higher rate of UTI. So when the nurse goes ahead and orders a urinalysis before you get in the room, I don't get worked up about waste. The urinalysis is often stone cold normal, which can perplex families who were certain that the dysuria would be a UTI. But not us, because we're going to take that back to the patho to understand why dysuria occurs even when it's not a UTI. It all comes down to a real estate issue. The impacted stool takes up more space, and the rectum expands to accommodate it. In time, this can lead to a loss of elasticity and sensation to have a bowel movement. So when there's more stool than expected in the large intestines, it takes up space and pushes everything else out of the way. So the bladder, which is a muscle, gets displaced forward and crunched for territory. The bladder can't contract well when it's getting punched in the side by all that stool. So as it contracts to urinate, that may be painful. Or it can't appropriately squeeze to empty, leading to urinary retention and frequency. 25 to 30% of children with constipation have daytime urinary incontinence. So make sure that constipation is a part of your differential in these patients. I can tell that it's a common gap because the AAP Choosing Wisely list for urology specifically names it. They tell us, do not treat urinary incontinence in a child with pharmacotherapy like anticholinergics before first evaluating and treating constipation. You know how else I know there's a gap? Because as I was helping our medical center implement a constipation guideline for the ED and urgent care, everyone was surprised when the other P&P in the room and I insisted that we include males with dysuria and no evidence of UTI on the eligibility criteria. Wait, that's something you see in urgent care and emergency departments? Yes, all the time. So after you rule out a UTI, just treat the stool impaction and functional constipation. And remember, constipation is a clinical diagnosis that does not require any testing if you have ruled out that there are no red flags for alternative diagnoses. Here's another Choosing Wisely recommendation that you can rest your hat on with reassurance to the family. Those red flags are all symptoms that accompany constipation as a secondary symptom of another primary diagnosis. What does that mean? It means that something else is causing the constipation, plus another symptom, that red flag. And when you rule out those red flags, which are all listed on Table 5 of the Tabors et al. Constipation Guidelines, you can feel confident moving forward with a diagnosis of functional constipation. Abdominal radiographs are not needed. Asterisks, except in some rare occurrences. I'll get to those in just a minute. And the reason for that is they're more associated with diagnostic error and subjectivity, leading to poor sensitivity and specificity, not to mention the unnecessary exposure to radiation that we should always try to minimize as much as possible in children. How many times have you read a film that reads, moderate stool burden? Hello, we all have a moderate stool burden. I found that the only time a film is really helpful is when there's a child who's in so much pain and I'm trying to decide if we should consider an inpatient admission for a clean out. If there's a stool ball in the rectal vault that will be too difficult or painful to expel without support, then that's a good indication to me that this child needs to be admitted for a clean out instead of trying to do it at home. All right, I've got a public service announcement. Actually, it's more of a Becky Carson service announcement. As the wife of a pediatric gastroenterologist, I would not be doing my job as an educator or spouse if I did not share with you this very important final recommendation from the AAP Choosing Wisely gastroenterology list. And that is, please avoid referral to pediatric gastroenterology for children with functional constipation without attempting standard, guideline-based laxative strategies. Let's save those appointments for the children who really need expert care. If you need a refresher on how to manage the clean-out and maintenance therapy, go back to listen to an oldie but a goodie, the Peds NP Episode 2, What to Do with the Poo. I'll give you a really high-level summary. Okay. A child who presents with pain, enuresis, encopresis, or just persistent Bristol 1 and 2 stools deserves a diagnosis of functional constipation with impaction and should go home with a clean out first. A cap of Miralax daily is not gonna cut it. Do the clean out over 1 to 3 days, depending on the needs and preferences of the family. use Miralax at a dose of 4.5 grams per kilo to a max of 16 caps and mix it in a ratio of 1 cap to 4 ounces with some kind of sports drink. They should drink the entire volume within 4 hours. And please, please, please don't forget to add senna twice daily. Why? Because those distended bowels need that squeeze to remind them to push the stool through. The softened stool just won't move without a little nudge from the natural stimulant laxative. Senna is the most underrated, under-recognized hero of bowel therapies. It's really well tolerated and will get that sleepy gut moving. It's not an everyday medication like Miralax, but it is essential for fecal disimpaction to help you start off with a blank slate in the gut again. Warn parents that children undergoing a fecal disimpaction or cleanout can get some tummy cramps, and those usually subside after having a bowel movement. You're going to have families who insist that their child stools every day. So how could they be constipated? I remind them that what goes in must come out. And when what goes in doesn't come out at the same rate or with a ease and consistency that's conducive to a nice Bristol 4 stool every day, there's a backup, and that leads to a territory battle in the belly, and that's what led to these other symptoms. Sure, we'll avoid cognitive bias and always keep other etiologies of enuresis and incompresis on the differential in the back of our minds, but I wouldn't make any other diagnostic moves until a cleanout is completed. And once the cleanout is done, you can begin the maintenance dose of Miralax with a PRN Senna rescue for if they don't stool in over 48 hours. Remind the family of how Miralax works. It's not absorbed into the body at all. It pulls in water to make the stool soft, and they may have to stay on it for weeks or even months. And they can play with that dose at home. Maybe half the dose, maybe give the dose every other day. Whatever it is to get the desired effect. One easy, soft bowel movement per day, at minimum. And the final critical part of the post-cleanout long-term management of functional constipation is to initiate good potty habits, encourage exercise, and work on their diet. These are things that will help the child to make better use of their pelvic floor, avoid withholding behaviors, increase the bulk of stool with fiber, get their gut moving with a little bit of exercise, and in general, set them up for a successful bowel regimen once the medication can be withdrawn. The AAP's Choosing Wisely pediatric lists span acute care, subspecialties, preventive care, diagnostic, and therapeutics, with over 75 recommendations in total. Our series has talked about 13 recommendations from 8 different specialty lists. From not ordering an echo and syncope to skincare and diarrhea, and picking antibiotic therapies that consider acuity and microbiology, these guidelines help us to avoid what is unnecessary and practice smarter. But awareness alone isn't enough. Casto et al. In 2024 reported on research that showed that raising awareness doesn't always change behavior and suggested de-implementation science, structured quality improvement efforts that engage teams, monitor data, and redesign systems to support high-value care. And that sounds like a good D&P project to me. After all, that is what we do as D&Ps to help ensure that evidence-based practice makes it to the bedside. So for those of you out there who are thinking about doctoral study and can't wrap your head around the problems of your practice, I suggest reviewing these lists to identify where waste exists in your clinical site. And then call me. We know that there's room for improvement. Awareness of the campaign across pediatric practice remains low, and I saw it firsthand. When I first presented this work at our national NAPNAP conference, I had a room filled with people who chose the session because they had never heard of the Choosing Wisely campaign. And when I queried the group in polls for how they would manage these cases, I was both surprised and unsurprised to find that lots of people were making choices that did not reflect the best evidence-based practice. Now, I'm not going to be harsh on my peers because some people might have been answering questions on cases that were outside of their typical setting. And frankly, I'm a very good item writer. My distractors are so enticing. But the nods and wide eyes and jotted notes I saw in the room told me that I was sharing information that was novel and contrary to their typical practice. And let's be clear, there is no shade here. We call our work practice because we work to improve each and every day. So what can you do to help improve your high-value care and spread the word on Choosing Wisely? Well, first, partner with your colleagues to offer support in waste-reducing strategies. This should be a continuous and evolving process that takes place regularly to evaluate current practice and identify areas where you could improve outcomes. Our practice changes all the time when new and compelling evidence emerges from the literature. You don't have to wait for best practices to become a Choosing Wisely recommendation to implement it. Part of partnering with your colleagues involves bolstering our communication skills and fortitude to stand up for evidence-based practice and explain to families why we should not do a desired intervention. Ensure that there is current, accurate information about the cost of healthcare and that everyone has access to evidence-based clinical guidelines to guide their discussions with families. Considerations of cost-effective care is a competency listed for advanced practice nursing in the AAC and Essentials and should be a consideration for all of us to provide equitable care. Go out and create systems that allow adequate time for conversations between clinicians and patients, and support financial systems that reward high-value care rather than the number of tests or treatments ordered. And when you hear the Peds NP harping on remembering the acute care differential, remember that a big part of that is clear, objective return criteria, not ordering extra tests. Remember that effective communication, more than the number of tests orders or medicines prescribed, is what drives patient satisfaction with care and prevents litigation. This goes back to bolstering our communication with families. I love to give if-then plans and tell a family, if this certain thing happens, then yes, we will absolutely get that diagnostic study. Or if this happens, please come back and we will look at it with new eyes. But since all of these green flags are waving, I just want to watch your child at home for any yellow or red flags and seek care if they pop up. You can empower families by employing them as your eyes at home to watch for those return criteria and encourage them to engage in discussions that surround medical decision-making and plans. Before we go, I want to highlight a couple of my colleagues at the Duke University School of Nursing and issue a call to all of you listeners. Dr. Marilyn Orman is a profound scholar in nursing education. If you have a degree in nursing, she has definitely written at least one of your textbooks. She shared with us recently how important dissemination is to the science of nursing. If your grand knowledge and understanding never escapes your brilliant brain to be shared with the public, then how can patients ever benefit? And while the article is still the golden currency of dissemination, I was surprised to see that social media was right below it, towering over conference presentations and posters or lectures at a local institution. Podcasts can reach the corner of the globe with a simple little thing called the internet. Which brings me to my good friend and colleague, Dr. Melinda Teague. She flips the script on homework assignments and presentations for her PNP primary care students by emphasizing that education is a form of advocacy. When we learn about the most current best practices and new research, we're advocating for evidence-based practice to improve the outcomes of children. And isn't that what we're all about at the Peds NP? You're here because you care about kids. And as you saw with the Acute Care Faculty Series, written by faculty across the country with expansive expertise in specialty areas, the podcast is a great place to share your knowledge. So if you've got an expertise that you want to share, I invite you to reach out to me and let me help you write a podcast script for the Peds NP. You don't have to be a Duke student or a NAPNAP member, just a pediatric-focused provider who's passionate about sharing your brilliance with the world. Email me at thepedsnp@gmail.com or DM me on Instagram at thepedznppodcast. I hope that you've enjoyed this series on the Choosing Wisely campaign and how it shapes evidence-based practice in pediatrics. This was our last case in the series, but the conversation doesn't stop here. These principles should guide every decision you make as a pediatric provider. Remember, high-value care isn't just about cost. It's about reducing harm, improving outcomes, and being a good steward of resources. Don't forget to like and follow the Peds NP, where we break down the practical application of evidence-based practice in a conversational way that helps you synthesize and transform the best recommendations from the literature into your bedside skills. Thanks to the Acute Care PNP faculty who reviewed this episode and supported quality assurance throughout the series. The Peds NP is built on grassroots foundations and communities of interest. So share it with a colleague, pass it along to your classmates, and text it to a friend. There are no relevant disclosures for this episode of the Peds NP. And remember, this isn't just a podcast. Those tricky situations in pediatrics become easier when you've got strong skills in how to think and choose wisely. I'm Becky Carson. Take care.